So again, welcome to the Orlando GI Journal Club. This is January 4th. Today is January 4th, 2023. We will proceed. So our first study is a randomized trial comparing vonoprazan with lansoprazole for patients with erosive esophagitis. This study is important in our clinical practice because although PPIs are effective for healing erosive esophagitis, some patients do not achieve success with conventional PPI treatment, and lack of healing of erosive esophagitis within 8 weeks of PPI therapy does occur in 5 to 20%. And after healing, recurrence over 12 months can occur in 10 to 45% of cases despite PPI therapy. An alternative to PPI is a potassium competitive acid blocker, and it does provide a more potent inhibition of gastric acid than PPI. But the current studies performed are based in Asia, and therefore these authors felt that it was important to conduct a randomized trial in Europe and the United States. So these authors performed a randomized trial to compare potassium competitive acid blocker with PPI for healing and maintenance of healing in erosive esophagitis. The authors therefore conducted a randomized trial that was double-blind, parallel group, involving 77 centers in the United States and 34 centers in Europe. They included all patients over the age of 18 with erosive esophagitis on endoscopy. They conducted the study in 2 phases. First was the healing phase, where patients randomized in a 1-to-1 ratio to vonoprazan 20 milligrams daily or lansoprazole 30 milligrams daily for 8 weeks. Then the second phase was the maintenance phase, where patients who demonstrated healing after 8 weeks of therapy were re-randomized in a 1-to-1 ratio to vonoprazan, either 10 or 20 milligrams daily, or lansoprazole 15 milligrams daily for 24 weeks, and the primary outcome was to look for healing by week 8. So over 1,000 patients were enrolled in this randomized trial. In the initial healing phase, 514 in the vonoprazan group, 510 in the lansoprazole group. Then around 900 patients qualified for the maintenance phase, 291 in the vonoprazan 20 group. Vonoprazan 10 milligram group had 293 patients, and 294 patients in the lansoprazole 15 milligram group. The severity of esophagitis were fairly evenly distributed in all the treatment groups, with about a third having a grade A esophagitis, about a third having grade B esophagitis, about 30% having a grade C esophagitis, and 3 to 4% having grade D esophagitis. In the healing phase, when the authors looked at the rate of healing by week 8, the rate was at 92.9% in the vonoprazan group versus 84.6% in the lansoprazole group. When they looked at the 24-hour heartburn-free days, the mean days were 66 days in vonoprazan and 64 days in lansoprazole. When they looked at healing by week 2, the rates were 74.3% in vonoprazan versus 68% in lansoprazole. When looking at the maintenance phase, when they compared the healing that was maintained, it was 80.7% in vonoprazan 20 milligram group, 79.2% in the vonoprazan 10 milligram group, and lansoprazole achieved healing, maintenance of healing of 72% after 24 weeks of therapy. When they looked at the overall difference with confidence intervals when comparing the 2 doses of vonoprazan, it was 8.7, And when comparing vonoprozor with lansoprazole, it was 7.2. When they looked at just patients with grade C or D esophagitis, again, the difference between vonoprozor 20 milligram and lansoprazole 15 milligram was 15.7%, and between vonoprozor of 10 milligram and lansoprazole was 13.3%. The adverse events rate was 30.2% in vonoprozor 20 milligram group in the healing phase, and then 54 to 56% in the maintenance phase. Lansoprazole, in the lansoprazole group, adverse event rates were reported in 29% in the healing phase and 50% in the maintenance phase. However, the rate of serious adverse events were low, with ranging from 0.4 to 5.7% in the vonoprozor group and 0.8 to 2.7% in the lansoprazole group. The limitation of the study is that this is primarily a white European US population, therefore limitation on generalizability of the study is limited to other ethnicities. In patients with H. pylori infection, also were excluded from the study, and also the results are applicable only to patients with erosive esophagitis and cannot be generalized to all patients presenting with GERD-like symptoms. So take-home point is that vonoprozor was non-inferior and superior to PPI in healing and maintenance of erosive esophagitis in patients negative for H. pylori infection from the United States and Europe. The differences in favor of vonoprozor was greater in patients with LA grade C or D esophagitis than those with LA grade A or B esophagitis. Our second study looks at the risk of recurrent acute arterial events associated with thiopurines and antitumor necrosis factor in IBD. The study is important because patients with IBD are at increased risk of acute arterial events, strokes, ischemic heart disease, and peripheral arterial disease, and treatment with anti-TNF agents have been associated with protective effect against the first occurrence of acute arterial events. What these authors wanted to do was look at the impact of anti-TNF agents in patients who already had acute arterial event in IBD patients. So they looked at the impact of anti-TNF alpha and thiopurine exposure on the risk of recurrent acute arterial events in patients with IBD and previous history of an acute arterial event. So this was a population-based retrospective cohort study using the French Administrative Health Database known as SNDS from 2006 to 2018. They included all patients over the age of 18 with recorded history of IBD and a previous history of acute arterial event. And they looked at the recurrence of any acute arterial event leading to hospitalizations, so any patients with recurrence of stroke, ischemic heart disease, and peripheral arterial disease. They included a total of 22,496 patients who were unexposed to anti-TNF alpha and thiopurines, who had IBD and previous history of anti-TNF alpha. And they also included 2,578 patients with IBD and previous history of acute arterial event who were exposed to anti-TNF, and 3,157 patients who had IBD, arterial event, and exposed to thiopurines. So it's a very simple math. Basically, they are wanting to compare the event rates of recurrent acute arterial event in patients exposed to and not exposed to anti-TNF and thiopurines. In the included patient population, ischemic heart disease accounted for the majority of arterial event, followed by stroke, and then peripheral arterial disease. So when these authors calculated the incidence of recurrent acute arterial event, so they ended up with over 120,000 person years. The event of acute arterial event incidence rate was 56.4%. That included 6,865 events, of which 3,894 were ischemic heart disease, over 1,000 CVAs, and over 1,500 peripheral arterial disease. The incident rate in patients who are not exposed to anti-TNF alpha and thiopurines for all acute arterial events was 58.3%, but 39.1% in patients exposed to anti-TNF and 45.2% in those who were exposed to thiopurines. Again, the event rate for recurrent arterial events were higher in patients who were not exposed to anti-TNF and thiopurines for all the subtypes of acute arterial events included in the study. So that was ischemic heart disease, cerebrovascular disease, and peripheral arterial disease. The authors also performed a multivariable adjusted hazard ratios for the incidence of recurrent acute arterial events. And they found that patients who were exposed to anti-TNF had a lower incidence of all acute arterial events. And that was also the case for patients who were exposed to thiopurines. The limitation of the study is the retrospective design and all its inherent limitations and biases. Also, because they're using a national database with a predefined variables that are included in this database, the information is incomplete on tobacco smoking, obesity, alcohol abuse, and the disease severity of IBD. So the take-home message is that recurrent acute arterial events were substantial in patients with IBD and previous history of acute arterial events. Exposure to both anti-TNF alpha and thiopurines were associated with a protective effect on the risk of recurrent acute arterial events. Our third study is by Penagini et al., published in CGH, looking at rapid drink challenge during high-resolution manometry for evaluation of esophageal emptying in treated achalasia. This study is important because incomplete esophageal emptying is a key variable predicting symptom relapse after achalasia treatment. And timed barium esophagram is the gold standard for evaluating incomplete esophageal emptying, but incomplete esophageal emptying can also be identified on rapid drink challenge during high-resolution manometry. This is important because it has potential to kill two birds with one stone, measure the pressure gradients during manometry, and also assess for incomplete esophageal emptying without exposing the patient to a second test and radiation. So a rapid drink challenge comprises 200 milliliters of water that is rapidly ingested through a straw, and then the esophageal body pressurization and elevated pressure gradients across the J-junction is measured. And these are hallmarks of latent GJ obstruction. So the aim of this study was to evaluate if esophageal body and gastroesophageal junction variables during rapid drinking challenge can predict complete esophageal emptying on timed barium esophagram. This was a retrospective study based in Italy with a few patients also contributed by Central United States, patients with achalasia who were treated by any therapeutic modality that included pneumatic dilation, Perrin-Heller's myotomy, botulinum injection, underwent high-resolution manometry with rapid drink challenge, and timed barium esophagram within 1 month of each other. And the primary outcome was to evaluate if rapid drink challenge differentiates complete from incomplete esophageal emptying in patients treated achalasia against the gold standard of timed barium esophagram. They included a total of 175 patients in this study. 138 patients were asymptomatic, 37 patients were still symptomatic after treatment. The majority of achalasia subtypes were type 2, followed by type 1, and then type 3. The most commonly performed treatment for achalasia was pneumatic dilation, performed in 59.4%, followed by Heller's, and then the other treatment modalities, 1.7. So these authors then looked at the correlation between high-resolution manometry with a rapid drink challenge and timed barium esophagram. And as you can see, they looked at the different variables that you can measure when performing rapid drink challenge during high-resolution manometry, and then they compared it to delay in esophageal emptying when measured with timed barium esophagram and measured the area under the curve. When you're measuring the area under the curve, anything above 0.8 is considered fairly decent. Obviously, higher the correlation, the better your new test is against the gold standard, which in this case is timed esophagram. And as you can see, the area under the curve ranges from about 0.6 to 0.75. And then it gets a little higher and better when looking at the IRP, when also looking at the trans EGJ gradient, and also the single swallow IRP measurements. The authors then also calculated the Brasiva operating characteristics curves for the rapid drink challenge IRP, the rapid challenge drink challenge EGJ gradient, and single swallow IRP measurements, and then compared it to timed barium esophagram at 1 minute, 2 minutes, and 5 minutes. And if you look at the rapid drink challenge IRP measurement, the area under the curve is all above 0.8, with area under the curve of 0.85 at 1 minute, 0.87 at 2 minutes, and 0.85 at 5 minutes. The main limitation of the study is that this is a retrospective study with no high-resolution manometry and timed barium esophagram results available prior to any treatment that the patients underwent. And also the majority of patients underwent pneumatic dilation for their achalasia and then Heller's, and then it was a very small number who underwent POEM. The main take-home point from this study is that rapid drink challenge, when performed during high-resolution manometry, is an effective surrogate for timed barium esophagram in assessing esophageal emptying, especially in treated asymptomatic patients with achalasia. So to summarize, for this journal club, vonoprazan was non-inferior and superior to PPI in healing and maintenance of healing of erosive esophagitis in patients negative H. pylori infections from US and Europe. Differences in favor of vonoprazan were greater in patients with early grade C or D than those with grade A or B esophagitis. Recurrent acute arterial events were substantial in patients with IBD and previous history of acute arterial events. Exposure to both anti-TNF and thiopurines were associated with a protective effect on the risk of recurrent acute arterial events. And rapid drink challenge during high-resolution manometry is an effective surrogate for timed barium esophagram in assessing esophageal emptying, especially in treated asymptomatic patients with achalasia. Thank you so much for joining us for this month. Happy New Year again, everyone. I hope everyone has a wonderful January. Our next journal club will be on February 1st, 2023. Thank you so much for joining us again. In January, looking forward to a happy, healthy, and wonderful 2023. I'm wishing the same for everyone. Thank you so much. Bye.